peritoneum. It is a retroperitoneal organ. The anterior surface is partly covered by peritoneum and posterior surface is devoid of peritoneum. Now it is very important as far as peritoneum is concerned, what is intraperitoneal, what is retroperitoneal, this is sometimes asked from me. So this kidney is retroperitoneal and basically it derives its name from renal or nephro. Okay, so renal or nephro refers to one and the same thing. Anywhere in the terminology you come across renal and nephro that pertains to kidney, okay, means bean shaped. So kidneys are bean shaped, exactly. What you have that rajma bean, exactly the kidneys resemble that, okay, except for size. The size of the kidneys is large as compared to the bean, you naturally know it. And what is important about the size of the kidneys? Does it carry any significance? Sometimes we tell you this organ is this much in size. It's important, especially in case of kidneys. Now, as far as the kidneys are concerned, 10 to 12 centimeters in length, 5 to 6 centimeters in breadth, and almost 2 to 3 millimeters in breadth. So that are the normal dimensions of the kidney. Now, coming back to the fact that I told you kidney size is important. Why is kidney size important? Because there are certain cases in which the kidney size gets increased and certain diseases in which the kidney size gets decreased, and that's very important. So we can just gauge certain diseases by the size of the kidney, number one. Number second, the cytoarchitectural changes in the kidney. That's another thing which we will be discussing later. So as far as the kidneys are concerned, the kidneys right and left, the important thing is that the right kidney lies a bit lower, okay, than the left kidney, okay. That is one part. Now another important part is that the kidneys, as you can see over here, the kidneys in here, this would be normally, but it is not like that. The kidneys lie almost at an angle like this. That means if this is the kidney, one kidney and then another kidney, they lie not straight, they lie at an angle like this. So once they lie at an angle like this, that means the upper poles of the kidney are nearer to the midline and the lower poles are far away. So this is the normal position of the kidney, okay. So that means the upper poles are nearer to the midline and the lower poles are away from each other. So that is another thing. Now, as far as the kidneys are concerned, important is that what are the surfaces? Just get him inside. These are the upper pole and the lower pole. The two surfaces, the anterior surface and the posterior surface, and the border, medial border and the lateral border. So this will be the upper pole, this will be the lower pole. This will be the lateral margin and this will be the medial margin. And this would be the anterior surface and facing backwards would be the posterior surface. Got it? So two poles, two surfaces, two borders. As simple as that. Now, important is hilum. Hilum of the kidney. As I was telling you last time, what is hilum? Hilum is the place wherein structures enter or leave the kidney. Okay, so that's important. So hilum of the kidney, the right kidney and the left kidney. And how do we identify the kidney? You are given a gross specimen of kidney, right or left, and how do you identify? Basically, the upper pole and the lower pole has a difference. The upper pole is a bit flattened, while as the lower pole is a bit pointed. Why? Because on the upper pole of the kidneys lies something which we give the name as suprarenal or the adrenal gland. So because of the weight of the adrenal gland, which are not that much heavy, but they compress the upper pole of the kidney. So the upper pole of the kidney is a bit rounded and the lower pole of the kidney is pointed. That's important. And the anterior surface of kidney is a bit rough and the posterior surface of the kidney is smooth. So that's important. So anterior surface and posterior surface. So this is how you recognize. Important. And the hilum, the structures which come and leave the renal hilum are the renal vein, the renal artery and the renal pelvis. VAP, vein, artery, pelvis, from anterior to posterior. That is very important. because you have to remember the position in the portal, the portal tract, and over here as well as the kidney. In kidney, the structures are vein, artery, pelvis, renal vein, renal artery, and renal pelvis, from which starts the ureter later on. So this is something about itself. So once you see the anterior surface of the kidney, so once you see the anterior surface of the kidney, the right kidney and the left kidney, it is important to recognize certain important. This is a question asked. This is question asked, image-based question. So anterior surface of kidney has which structures attached to it, the right and the left, as you can see over here. I just mentioned you the suprarenals lie at the top of the kidney. Then over here, this is a large area, and it is occupied by the right lobe of the kidney. To be more specific, hepatic lobe, right lobe of the liver. And this is the duodenal area, this is the jejunal area, and this is the colic. So we go reverse: duodenum, jejunum, and large intestine. Okay? So three important areas: suprarenal, hepatic, duodenal, jejunal, and colic area. I mean to say right kidney. Then the left kidney. We have again the suprarenal, though the shape of the right and the left suprarenal differs. Then we have got the gastric area. Okay, and then here is the area which is the distal part of the pancreas, pancreatic area, because pancreas head to tail. Okay, pancreatic area. Then we have the colic area and the jejunal area. Okay, and that is the left kidney. So these are the relations which you have to remember, because they carry a functional significance as well. Why? Because I will tell you at a later point. Now, as far as the posterior relations of the kidney are concerned, it is very, very important. Why it is important? Because there are two approaches to kidney. One is the anterior approach. Some surgeons approach the kidney through anterior, and some surgeons approach through posterior, from back. But most of the surgeons prefer back. So that is why the posterior relations of kidney are important. And as you can see in the figure, the relations of the kidney are the diaphragm over here, and the medial arcuate ligament and the lateral arcuate ligament. Assuming that this is which kidney? The left kidney. So this is the medial arcuate ligament, this is the lateral arcuate ligament, and this is the area of the diaphragm. So what is medial arcuate ligament and what is lateral arcuate ligament? I will tell you later once we study diaphragm. Then important is that there are three muscles. And what are the three muscles? The psoas major medially, the quadratus lumborum in the middle, and the transversus abdominis laterally. So psoas, quadratus lumborum, and transversus abdomen, they just span the posterior part of the kidney. They are important as far as posterior surgical approach to the kidney is concerned. And there are the subcostal vessels and nerve, iliohypogastric nerve, and ilioinguinal nerve. So three nerves: subcostal, iliohypogastric, and ilioinguinal nerve. That is very important. These three nerves are important from an academic viewpoint, and they are also important as far as the posterior relations of kidney are concerned, along with the vessels, the subcostal vessels. So subcostal vessel, iliohypogastric nerve, and ilioinguinal nerve, along with the subcostal nerves. So that is very important. So this is something about the posterior relations of the kidney. Now, once we dissect the kidney, we go for the dissection of the kidney. Do we come across, now we have reached, assume for all practical purposes, that we have penetrated the posterior abdominal wall, and now we have reached the kidney, just starting from inner side to outer side. So what lies, what covers the kidney? So kidney is covered by a capsule, in way other organs are covered by the capsule, and the liver is covered by the capsule. So the first thing is the true capsule, the renal capsule, which is nothing but a condensation of the substance of the gland itself. That's the true capsule. Okay. Then after there is some, you can see yellowish, and yellow refers to fat, adipose tissue. So there is a, cushion of fat, which we give the name as perirenal pad of fat or perinephric pad. This is perinephric. Okay, this is important. Then over the perinephric pad of fat, there is renal fascia. Very important. fascias are important. There are so many fascias in the body. Pulleys fascia, Walder's fascia, and anything you remember? Pardon? Fascia lata, isn't it? So many. But over here, there is this renal fascia, and the important part about the fascia of the kidneys is that it is usually composed of two layers, the anterior layer and the posterior layer. And the anterior layer is given the name as fascia of Gerota, Gerota. And the posterior layer is given the name as fascia of Zucker-Kandel, Zucker-Kandel, Zucker-Kandel. So anterior layer is the fascia of Gerota, and posterior layer is the fascia of Zucker-Kandel. You got my point? So that is one part. Then above the renal fascia is the pararenal pad of fat. So over here, just over the renal fascia lies the pararenal pad of fat. Sorry. So that is important. So over the renal fascia lies the pararenal pad of fat. Now, as far as this renal fascia is concerned, the anterior layer and the posterior, usually on all the sides you have these two layers, but it is not a uniform distribution superiorly, uniform distribution inferiorly, uniform distribution medially, or uniform distribution laterally. So that's important. But you have to remember that the anterior and the posterior layer usually split just near the kidney and then just enclose the suprarenal after splitting. So one comes anteriorly, one comes posteriorly. So superior, the two layers split to enclose the suprarenal gland. And then it is said that at certain places it is not, to say, covering all the aspects. Somewhere it is related to the undersurface of the diaphragm on the right side and the left side. Okay? So that's one part. Laterally, it goes laterally. This renal fascia goes laterally and it embeds with the fascia on the lateral side. There's a lot of fascia over there, and there are the parapoli gutters more laterally, so it blends with the fascia. But medially, you have to remember that this fascia is tight. And what is important, that this fascial attachment medially prevents the spread of infection from one kidney to another. Okay, so it is condensed, not that well organized medially. That's important. Inferiorly, it goes down and it goes towards the pelvis and merges with the pelvic fascia. So it is important, but mainly you have to remember fascia of Gerota and fascia of Zucker-Kandel. So this is something about the kidney as far as the coverings of the fascia are concerned. Now, I told you, once we go and we just go to the surgical aspect, if this patient has got any problem with the kidney and he needs a surgical approach, so most of the surgeons prefer posteriorly, because anteriorly there's a lot of peritoneum and all those things, so many structures, so mostly they prefer posteriorly. So what we encounter after skin and all those things, the first thing which we encounter is the posterior layer of thoracolumbar fascia. Now I was telling you fascias. Fascias are important. So you have three layers of thoracolumbar fascia. One is the posterior, one is the middle, and one is the anterior. So once we go from posterior, natural, common sense is that posterior will come first, the middle will come later on, and the anterior will come on deep inside. So the first layer which will be there will be the posterior layer of thoracolumbar fascia. And just once we just go dissect, then there will be the erector spinae muscle, a muscle which erects the spine, I would say, almost a longitudinal muscle, erector spinae, okay, responsible for the spine erection, okay, that will come. Then we will have the middle layer of thoracolumbar fascia, that is demonstrated in this figure. So posterior layer of thoracolumbar fascia, erector spinae, and then the middle layer of thoracolumbar fascia here. And this is all attached to the vertebra, because you have not studied vertebra as the spine, the transverse process, what is attached, and you can make it from here as well. So this is attached to the spine and this is attached to the transverse process and the facet. So over here, this is the quadratus lumborum muscle over here, which is present inside the medial to the middle layer of thoracolumbar fascia. And more medially is this very important muscle, psoas major muscle. Psoas major is a very important muscle as far as abdomen is concerned. Together with iliacus, it is called as iliopsoas, And basically why it is important, I will discuss it at some point of time. Psoas major is a big muscle and it comes more medially. So erector spinae, quadratus lumborum and psoas major. Then you will be having the anterior layer of the thoracolumbar fascia. Then as I mentioned you just, there will be the paranephrine pad of fat, which I told you. You can see over here, it is the most paranephrine, it is the outermost. Then there will be the renal capsule. So this will be a renal fascia first. Then the renal perinephric pad of fat. Then the renal capsule. So going from a surgical viewpoint, posterior layer of thoracolumbar fascia, erector spinae, middle layer of thoracolumbar fascia, quadratus lumborum, anterior layer of thoracolumbar fascia, and medially psoas major. Then, after that, you will be having something like what I told you, pararenal pad of fat, going interior. Then the renal fascia, then the perirenal pad of fat, then the renal capsule, and then we enter into the substance of the kidney. So this is how the surgeons approach the kidney. So these we have to remember. This figure is also asked. So very, very important. How you go for a surgical approach of the kidney. So that's important. So this thing you can just remember as well. Now, moving further. So once we have, important is that posteriorly, what is the area of the kidney posteriorly? How do we define the area of the kidney? So T11 vertebra and L3 vertebra. So you have to remember at the onset I should have mentioned this. The kidneys lie between T11 and L3. So T11 and L3. And you go from the midline spine 9 centimeters laterally, right or left, and then you just draw a horizontal line, and at 9 centimeters you draw a vertical line. This is something like a parallelogram, and this is given the name as Morrison's parallelogram. So the chances of locating the kidney posteriorly in the Morrison's parallelogram ranges from 75 to 90%. So this is Morrison's parallelogram, and how do we define the Morrison's parallelogram? Between the vertebral valves T11 and L3, it is like that, and then 9 centimeters laterally, okay, from the midline. So the most you draw 2 horizontal lines and a vertical line. This is given the name as Morrison's parallelogram. So this is something about the surgical anatomy of the kidney. Now, what is important about the kidney is that there is the renal artery and the renal vein. And the renal artery supplies the kidney, and the renal vein takes blood away from the kidney. So, as you are aware, you saw at the hilum of the kidney that there is the renal artery and the renal vein. So over here as well, in this figure as well, there is the renal artery and the renal vein. So the renal artery is a branch of the abdominal aorta, and renal veins drain into the inferior vena cava. So these are two big vessels present in the posterior abdominal wall, okay? And these two structures, they, I mean to say, give blood supply to the kidney as far as. Now, is there any other importance of the renal artery and renal vein? Yes, because this area over here, the hilum of the kidney, there's a lot of variation in the renal vessels. Sometimes we have double renal vessels, okay, or aberrant renal vessels. That's important. Why? Because if somebody is doing a surgery, and a surgeon for all practical purpose assumes that a patient has only one renal artery. So he has urgency to go to other clinic, or second patient is waiting outside, and he has to perform a surgery, isn't it? Lot of cash involved. So then he is in a bit of hurry. He does not recognize the other renal artery, and extensionally he or she cuts the renal artery. So what can happen? So once he moves out of the theatre, he goes home. Once he is driving or reaches home, he can receive a call that the patient is collapsing, isn't it? Then if he does not go back and does not have a look at it, isn't it? Then tomorrow he finds the same patient's photograph in the paper, dead, and he is, I mean to say, he recognizes, yes, he was the same person I operated yesterday, isn't it? So it's just like that. But important is that you have to recognize this aberrant renal artery, which is present in what? It's a good, I would say, I have my paper as well on this thing, and there's a lot of I would say, 10 to 20% in Indian population, I guess. I don't remember it exactly, but there's a lot of variation in this, and epithetic vessels are quite common. They are not that rare. Okay, so that's important. Second thing is that nowadays we have this renal transplant, isn't it? Renal transplant is done in many cases, and so what is important? Kidney should be compatible, isn't it? That's one thing. Immunologically compatible. But another thing is that if one kidney has got, say, donor has got 2 renal arteries, and the recipient has got only 1 renal artery, or the recipient has got 2 renal arteries, and the donor has 1, will it succeed? So first of all, before doing renal transplant, we do a renal angiogram. And what is the renal angiogram? We just put in a dye and notice the pattern of the renal vessel, both in the donor as well as in the recipient, so that they are having almost the same configuration, 1 or 2 vessels, and so they can just do the anastomosis rightly. Okay, so this has got a practical implication as far as the kidney is concerned. Now, basically, what's important in medical terminology is 2 things, especially in males. The testes descend and the kidneys ascend. That's important. Kidneys in embryonic life are present in the sacral region, and then they ascend. Say sometimes the kidneys fail to ascend. Would you see the kidneys in the location of T11, L3? No, they will not be there. So they will be down. And what's important is that these unascended kidneys, they retain the blood supply of the pelvis. Pelvic vessels supply these. Then they are not supplied by the vessels of the abdomen, like the abdominal aorta, or they do not drain in the inferior vena cava. So that is very important that we have got a clinical condition which is just a sort of I would say ectopic position of the kidney, okay, which is quite, I would say, ascending. Okay, ectopic position of the kidney is something else. That means the kidney does not lie or has migrated from its normal position to other position. That's called as visceroptosis. What is visceroptosis? Once a viscera is not present in its own area, okay, it is present at a certain other area. That is visceroptosis due to many factors, and kidneys can be present at some other place, I would say, beyond the Morrison's parallelogram. That was the reason I told you about something at Morrison. But I am telling you here about unascended kidneys, okay, which lie in the pelvis, in the sacral region, okay, and then they do not have the blood supply same as this thing. Now, another thing is that you know that kidneys are quite common areas for stones, isn't it? So you can have kidney stones, quite a common problem. Nephrolithasis, okay, accumulation of I would say due to uric acid, due to calcium phosphate stones, many varieties of say. Okay, so they can be nephrolithasis. So depending upon the biochemical composition of citrates and calcium, phosphate, oxalates, you can have so many types of stones. But my point is that the kidneys are a common site like the gallbladder for the lodgement of the stones. And sometimes once this kidney, the stone comes down in the ureter, you get a sort of a ureter colic. Okay, so that's important. So kidneys have got sometimes deportion. Now there's another important thing which I would just like to mention, because some of the practitioners go on, you go to a practitioner and you tell a practitioner that I'm having weakness, fatigue, and then he bombards you with iron, calcium, and a lot many things. And what happens, unfortunately, some people do over medication with calcium salts and supplements. And what happens? This calcium gets deposited in the kidneys, and that clinical condition as a result of excessive intake of calcium, vitamin D is given the name as Anderson-Carr kidney, A-N-D-E-R-S-O-N, Anderson-Carr kidney, wherein there's a lot of deposition of calcium within the kidney. Okay, so that's one part. So kidneys, as far as nephrolithasis is concerned. So sometimes what happens now, the size. I told you at the onset, just the size of the kidneys is important. I mentioned you the size. Sometimes the kidneys enlarge in size. Okay, and that is very important. The kidneys enlarge in size, and normally they exceed the size they should have. And that is a very important, that especially in case of renal masses, renal cell carcinomas, renal tumors, RCCs which we call, okay? The renal kidney is a common site of cancers, and RCC is one of the most important cancers of the kidney, and there we have what renal megaly sometimes. That's important. And another important point over here to mention is the veins. The renal veins are quite notorious because RCC secretes renal veins. Very important. Very, very important. So renal veins are a very common source of metastasis from RCC. Okay? You will find thrombus usually in the renal veins once one has got RCC. That's important. In addition to that, the kidney gets injured in abdominal blood trauma, and you can have a complete tear, partial tear of the kidneys. And sometimes the kidneys can be small. That's very important. Okay? Shrunken kidneys, chronic renal disease or chronic kidney disease, CKD. That is very important, and chronic renal disease is one important fact which causes shrunken kidneys. So by having a small kidney, one can get a rough idea, maybe it is a chronic renal disease. So that is very important as far as the size of the kidney is concerned. Then kidney is one of the organs which is commonly involved in diabetes, diabetic nephropathy. Diabetes affects certain important structures, okay? Nerves, diabetic neuropathy, eyes, diabetic ophthalmopathy, and diabetic nephropathy. So these are three important organs which are affected by diabetes, and kidney is one of the most common causes. The renal failure is one of the most common causes of death in case of diabetics. That's to be taken care of because the size of the kidney is shrunken. Okay, along with the cytoarchitectural changes which I told you at the onset, but I will tell you at the end of the class that corticomedullary differentiation gets changed. You can see in a kidney differentiation between the cortex and the medulla. Once that differentiation is gone, it is one of the signs of chronic renal disease. That's from a perspective of an ultrasound. You just need to know, but you have to remember what's corticomedullary differentiation. That you can grossly see the kidney, cortex, and the medulla very well on ultrasound as well. So that is CMD, corticomedullary differentiation. Then renal stones, I told you. Also, there can be sometimes accumulation of pus. Kidney is a common site for tuberculosis. Okay, renal tuberculosis. That is one important thing which affects the kidneys. And then the removal of the kidneys is called as the nephrectomy. You cannot remove both the kidneys. Okay, you have to keep one functional kidney. And usually there is sometimes agenesis of one kidney. Okay, there are certain syndromic agities in pediatrics where you have got hypoplastic kidney. One of the kidneys is, I mentioned, not well developed, and the other is well developed. So that is the hypoplasia, but you cannot have a condition in which a patient has got bilateral abscess of kidneys. That's incompatible with life. Okay, so don't give a report ultrasound report that this patient has both the kidneys absent. Okay, because things are moving to that direction. That some of the sonologists will soon report in elderly that he has absence of both the kidneys. Okay, then you know about the bionic kidneys that in case of chronic renal failure, the scientists all over the world have developed artificial kidneys, small of different sizes. Now they are decreasing in size, and that we give the name as bionic kidney, and they just do the exact function of the kidney. So that's important. So this is something which you have to remember. And kidney is also a very important area where we can have cysts. Okay, renal cysts. So renal cysts are very important as far as the kidney is concerned. Now, so this is what I was telling you, the renal calculi. So these are the renal calculi. These are the calculi in the region of the renal area. You can see. Okay, so this is the renal calculi. Now, this was something about the slide which I missed, the inferior vena cava, into which drains the right and the left renal vein, and the abdominal aorta from which the renal artery arises. Now, this is one important thing, which is a very interesting thing, that this is something which we give the name as horseshoe kidney. Once we have got the posterior poles of the kidneys fused, okay? So this is the horseshoe kidney. You know, once there are horses nowadays, not that you go to parallelogram and all these places, and you have the horse and these horse riders, they place those in horseshoe, exactly like this. And what is horseshoe kidney? Once you have the posterior poles of the kidney fused, anterior poles are like this. So this is typically a beautiful demonstration of a horseshoe kidney. Okay, then we have got pancake kidney. Pancake kidney is not horseshoe kidney. That important fact, the difference between a pancake kidney is that both the kidneys are present and they form a lower mass on one side. Okay, so pancake kidney is different from horseshoe kidney. This is the typical horseshoe kidney, and I told you pancake kidney. Pancake kidney is a lobulated mass which both the kidneys are just fused on one side, either the right or the left, very irregular in shape. So that's another thing which is given the name as pancake kidney. These are very important things. That's why we study kidney and I think renal cysts. The kidney is a common site for cysts, okay? And there are two types of cystic diseases. One is the childhood polycystic kidney disease, and one is the adult polycystic kidney disease, okay? So in which you have multiple cysts, and sometimes there are hundreds of cysts. Normally there are benign cysts, one or two present in the kidney. They're normal, I would say, present in healthy population. They do not do much. But we have to monitor the size of these, I would say, simple cysts. But there is this clinical entity, congenital polycystic kidney, in which you have cysts in the kidney over here, multiple, okay? And then what happens, over a period of time they grow and they replace the renal architecture, and the patient develops into chronic renal failure again because of the abnormal extension of the cyst and all those things. Okay, so that is chronic childhood polycystic kidney disease and adult polycystic kidney disease. So this is something about the kidneys. Nephrectomy is the surgical removal of kidney, and nowadays we have got partial nephrectomy which is done, so we can preserve a part of the kidneys. And I mean to say that's one. I think that much enough for today. And